What is Medicaid and who is currently eligible for it?
Insurance is just the standard way to do preventative care to avert emergencies that are expensive. It's a very good question.
How do we solve this problem? For listeners who want to take action, what can they do? Welcome to an episode of A Conversation with Carl. Please remember to like, follow, and subscribe for the latest content. Today, we're addressing a critical national issue, the alarming Medicaid crisis and the fundamentally right to quality health care. Joining us to discuss the national crisis is returning guest Dr. Monica Gandhi. Following her insights from yesterday's vaccine panel, Dr. Gandhi is a Harvard-trained infectious disease specialist, professor of medicine at the University of California, San Francisco, director of the University of California, San Francisco Center for AIDS Research, and the medical director of the Ward 86 HIV Clinic. Welcome back, Dr. Monica Gandhi, to the conversation.
Thank you for having me.
So for listeners who are not familiar, what is Medicaid and who is currently eligible for it?
So Medicaid is our health insurance program in the United States for low-income individuals. So what does that specifically mean? Well, number one, it is covering about 68 million Americans, and including children. And the criteria to be on Medicaid is really around your income. So if you are low income, meaning if you have low income seniors, your children, you are an individual with disabilities, these are particular groups that qualify for this insurance program. We don't have national health care in the United States, but this is as close as we can get to support people who are disabled or children or seniors who really need our help. So it just means that they're lower income. And what happened is, well, a lot has happened, but one thing that happened is that as soon as this new Trump administration started, there were a lot of changes made to Medicaid that are going to take effect relatively soon after the midterms.
On a recent vaccine panel, you mentioned that California is facing a Medicaid crisis that is stripping benefits from people who rely on them. What is happening in California right now, and how does it reflect what is occurring across the country? And you just mentioned that with Trump, in the Trump administration.
Yeah. So what happened is, as soon as Trump got in office, like one of his first acts actually was to say that Medicaid needs to be reformed, but specifically that there's going to be all this. The changes that are being proposed will kick people off of Medicaid, and even if you're on Medicaid, there's a lot of rigmarole that has to happen to keep you on Medicaid. Now, California, our Medicaid is called Medi-Cal, and what Governor Newsom said is he'll keep people on Medi-Cal who are undocumented immigrants, because that was another big change that Trump enacted, saying if you're an undocumented immigrant, not to be on Medicaid. The one problem with that is they do live in this country and they'll go to the ER and that will be extremely expensive, meaning emergency care is always more expensive. So there was a reason that we, provided healthcare coverage for undocumented immigrants. But at any rate, what Governor Newsom in California said is, if you're an undocumented immigrant, you can stay on Medi-Cal, but only if you're already enrolled. If you're a new undocumented immigrant, you're out of luck. No insurance for you. And again, I mean, people, if they physically live here, if you are in labor, if you are having a medical emergency, if your appendix is bursting, you will, of course, seek care. And the emergency room, we as physicians, not only are we not allowed, but I can't even imagine that anyone would turn away someone in distress. But beyond that, it is a Hippocratic oath that we take to as physicians to take care of people. So people will come in for emergency care, and that will actually lead to higher healthcare costs for the government, for the taxpayer. So it's short-sighted to not give people insurance. Insurance is just the standard way to do preventative care to avert emergencies that are expensive.
That point that you just made is you never turn anyone away, right?
Yeah.
When
cannot.
someone goes, you can't. So when someone goes into the hospital and people are now using the emergency room as a doctor's office.
Exactly. And that is so much more expensive and who pays for it? The American taxpayer dollars pay for it. I mean, they do, because if you cannot afford the care, someone has to pay for it. And so it will end up, it's just short, these kind of things are very short-sighted. It's like ounce of prevention is worth a pound of cure. Not having preventative care, not doing vaccines, not doing preventative care, cardiovascular care before you get to a heart attack. Not only is it devastating for the family where the person gets very ill or they get advanced cancer, but it just doesn't even make any financial sense from any health economic standpoint.
You're right. It doesn't seem right to how.
Right.
So who's losing coverage right now? Is this primarily a socioeconomic issue, or does it disproportionately impact communities of color? And if racial disparities are driving these losses, can we frame healthcare access as a civil rights issue and a form of systematic discrimination? I know there's a lot in there to unpack.
It's a very good question, because okay, so like going back to the qualifications, your income level has to be is based on your percentage of the federal poverty level. So many expansion states essentially say, okay, if you're earning 138% of the poverty line, then you can qualify for Medicaid. Like really, really low, you're pretty much at the poverty line. Then pregnant people, so pregnant women, whether they're rich or poor, actually Medicaid does cover their labor and delivery costs, which is excellent. So that loss will happen. And then people who are 65 and older, they get also coverage, for example, for assisted living through Medicaid. So it's even if they're wealthy. So again, it covers the pregnant women and older people. The criticism has been, Republicans, you're trying to cut low-income individuals out who are often racial and ethnic minorities. But what about pregnant women? Everyone wants pregnant women to succeed and have their children safely, and also older people. So that's been the criticism. But you're right. In terms of that qualification of the federal poverty level in this country, poverty tracks with race and ethnicity. It just does. Like low-income individuals are disproportionately Black or African American or Latino, and so there will be that is discriminatory. The problem is discriminatory doesn't hold any truck with this particular administration. Like meaning they're actually taking out from multiple. Even our history books, the question of racial and ethnic disparities. So that is not going to fly. But I think where we can make the appeal is it just doesn't make economic sense. It just doesn't. The ER will be tied up. The ICU will be tied up. And rich people can't get care. I mean, honestly, it's we have to make economic argument. But yes, it will affect racial and ethnic minorities more.
I mean, when you go to the emergency room, it's so crowded.
Yeah.
And I'm in New York City. But in New York City, it's always crowded. And I haven't been there a lot the couple times that I've been there. And I feel the question that I have always is it worth going when we have to have an issue? And most of the times, thank God there's urgent care now because there's a place to go. But when you're sitting there, you really think about the wait time and the process of going and who's using the
worst way to get care. It's just the way to get care is calm in a doctor's office, preventative care, vaccines. I mean, essentially, people have lost Medicaid coverage nationally already, but where the worst of this, I think, is going to happen is after the midterms, because there was this curious aspect of the bill that I don't think the Republicans and Trump wanted to be blamed for people being kicked off of health care before the midterms because it could make them unpopular for the midterms. So they said all of these changes will go into effect after the midterms. There's other unpopular things going on right now that may affect the midterms, though.
The government frames Medicaid restrictions as an effort to eliminate waste and refocus funds away from able-bodied adults. But being able-bodied doesn't mean someone can find a job with quality health coverage. So why is this official criteria for determining who's in the most need? Isn't the official criteria for determining who is the most in need flawed?
Yes. So there, it's a really good point. So, if we say that maybe 68 to 73 million people are on Medicaid at any time in this country, that isn't, the number of people in this country. Like it was kind of carefully curated, right? 300 million
Yeah.
people in the United States that usually these individuals really do qualify for Medicaid, or they qualify for low income health insurance, meaning disability, low income, seniors, pregnant women, children. Like I wouldn't any anything can have fraud, but that is usually a very minute proportion of the people who are being covered. And the kind of rigmarole that clinics are going to have to go through now. What they're going to have to do is every 6 months, they're going to have to prove to Medicaid that someone's, trying to get a job or going to school. By the way, with job loss, in this country, it's harder to get a job. So all these things are related. But usually people are on it because they really have other disabilities. So you can be physically well, but mental disability, mental illness will qualify to being on Medicaid. You may not be able to lift or carry things appropriately. Like you just can't. It's too heavy. You have limitations. And just the amount of documentation that is going to have to be done while clinics are short-staffed, because already it's harder to deliver care in this country. That to me is more waste and abuse, when you waste people's time, having clinics do this instead of providing care.
I was watching Bill Maher a few weeks ago, and he said one of the things that needs to happen is the GLP. They had on Scott Galloway, and Scott Galloway said one of the big things that needs to happen is the GLP-1 drug has to be given to people who are has to be opened up to all people on Medicaid, because that will somehow solve a lot of the issues that they're going through. I don't know if you would agree with that or not, or where the GLP-1 drug comes into this.
Well, actually, that's been a very interesting story, because what happened in January of this year, in anticipation of what's going to happen to Medicaid, there was a cutting out of GLP-1 agonists for a lot of people who are on Medicaid. So you can qualify if you have diabetes or known heart disease, or obstructive sleep apnea or a fatty liver, but not for weight loss. Now, the problem was that so many people got kicked off of GLP-1s with those changes in Medicaid that we have seen people kind of spiraling out of control, because what weight loss does is fundamentally affect your metabolic health,
Yeah.
does affect your cardiovascular risk. So you may not have actively cardiovascular disease right now, but you're going to get it without the GLP-1. And addiction, it's very interesting that GLP-1s have effects on addictive tendencies. And so people have been spiraling out, I can see in San Francisco, in addiction. So there's a lot of misery that GLP-1s should be cheaper. I mean, there's an oral formulation coming there, injectable, but that doctors don't. I would say this idea that there's like frivolous prescription doesn't make sense to me. You're actually pretty careful about what you prescribe. And for Medicaid, for a bureaucrat to decide who gets to have GLP-1s instead of the healthcare provider, instead of someone who's medically trained, that doesn't make sense. Same with vaccines. People who are medically trained, infectious disease trained, should be making these decisions, not bureaucrats, not politicians.
Yeah, the doctor should be. I mean, I feel like if I go to my doctor, I want my doctor to tell me. I mean, the amount of stuff and the amount of times that I deal with my insurance company can make me
Crazy, yeah.
It can make you crazy. And you feel like you're dealing with the insurance company and they're telling you what you can and cannot do. So can individual states step in to absorb some of these federal funding cuts and preserve coverage?
Yes, they can. They may not, given their own needs and their own decisions. But I think our state is a good example, California, that 1.6 million Americans were removed from Medicaid for the first, at the beginning of Trump's administration, about 6 months in. And states like California said, okay, we will cover people who've lost coverage if they really do qualify for Medicaid, especially undocumented immigrants. But California's in debt too, like states are in debt, and they're going to make decisions. They're going to say, once we really get into the pain of this, because the pain of this, again, is going to happen after the midterms. 1.6 million are a lot, but it isn't the number
What's
of millions
coming?
that are projected. Yeah, what's coming. And
Yeah.
after that, states will have to decide, oh, I'm going to spend my budget on this, on supporting people who are kicked off Medicaid by the federal government to support them on Medi-Cal, North Carolina, like whatever the equivalent is in the state. But they're going to have to make those decisions. And we have the most expensive healthcare system in the world. All of this has done nothing for us, right? Like all this quibbling about insurance all it does is make healthcare costs higher here. If you look at places with national healthcare insurance systems, which is almost every country in Europe, Latin America, I mean, it's a pretty standard thing. It's not everyone, but most places, UK, let's give that an equivalent, the national healthcare system. They have cheaper healthcare costs because preventative care is important to prevent you from getting very sick and being in the ICU. So it is just penny wise, pound foolish to cut on healthcare costs. Maybe we could think about other things to cut our national debt on, but healthcare is kind of fundamental. Also, it's the same thing about my medical research and NIH-funded research. You ask the average American what they want. They want like lifespans. They want longer lifespans. They want better life quality. Like everyone's into health. Everyone's into it. No one wants their family member to be sick. It's very basic. So I would say that let's see what states do come right after the midterms, which would be mid-November.
And then what options or safety nets exist for individuals who have already lost their coverage?
None. Someone was asking me this yesterday. And is there some even more basic healthcare insurance plan that people can get? No. This is the federal insurance plan, is Medicaid. Now, what would happen in a city like San Francisco is San Francisco and Massachusetts had a universal healthcare they tried to do their own form of universal healthcare. It's called Healthy San Francisco here. And the Massachusetts system, this was under Governor Romney, they did form a universal healthcare system. But that doesn't mean that it's intact. I mean, people are trying to rely on Medicaid, the federal government, and it would have to mean that states would have to construct universal healthcare insurance plans. If they choose to do so, they likely won't. There isn't some other way. It's what we just talked about. It's doing your emergency care and life-saving care in the emergency room and then suffering otherwise.
So what is the viable way forward? Is it a broader healthcare? Is it a nationalized system? Is it adopting a hybrid model or making coverage more affordable and accessible? How do we go forward? How do we solve this problem?
I mean, as a longstanding physician, I would always think that a national healthcare insurance system is what we need, like the National Health Service in the UK. It's hard for me to get away from that when I see low income and high income and everything that we see here at UCSF. You just need kind of a leveler. And then if someone wants to pay for higher quality care or higher level care or get to see a doctor in a concierge way, they can afford it. They can absolutely do that. That's what they do in the UK. But short of that, because I don't think this country maybe is ready for a national healthcare insurance plan, then we have to figure out, for example, other ways to achieve that, like keeping our Medicaid intact, which is for low income. Medicare for All is a single payer healthcare system proposal in the United States that would replace private and employer kind of sponsored insurance with one federally covered program that is really covering all U.S. residents. It wouldn't necessarily work on undocumented immigrants, so we'd have to figure out what to do there. But that kind of single payer is the national healthcare model that has been proposed. Medicare for All Act there's actually an active bill in Congress that was introduced even during this administration. It was introduced 4 months into the administration in April 2025. It's not yet going anywhere. Midterms will determine what Congress decides. Congress, depending on what happens in the midterms, could even say, no, this big bill is not going to work for people. It's going to be too expensive, so we're going to roll back these Medicaid cuts. Or they could go forth with the Medicare for All Act, and that would be as close as we could get in this for a single payer healthcare insurance system. And again, if you're wealthy and you want extra special care and you want access to doctors around the clock, that kind of stuff can always be paid for in a capitalist system like the United States. That will be paid for. We already have that now with concierge systems and so forth, like One Medical.
I was going to say that the concierge doctors are all around.
Exactly.
And yes, but
They'll always be available to people. Yeah.
But what I find fascinating about the concierge doctors is that when you get to retirement, you're going to have trouble affording it. But a lot of people are doing concierge that are working right now. But when you're in your 40s and 50s, you don't really need the concierge doctor that much.
Yeah, you need it. Everyone gets the illness that happens when we're older. There's no doubt.
Yes.
Yeah.
So, and I think about that because I was like, well, this doesn't make sense now because I know a lot of people pay into the concierge, but then I ask, how many times do you go see your doctor? And they're not going that often. So I think to myself, it's going to end up being in the end when you get to 65 and 70, and then it's going to be really expensive and you're going to have to decide what to do.
Yeah, though what I hope is if we have some sort of leveler of care, then 65 to 70-year-olds will get a lot of their care through the Medicare system if we get that for all. And we do have Medicare for older people. And then what we do is if you want that extra special, like, I want to see you today, then you can have your concierge. But I think the majority of emergency care will be performed by insurance. This kind of stuff isn't popular, like just rolling back healthcare and what people need for healthcare just isn't popular. And so I think like anything in this administration or any administration, once something extreme happens, there is enough public outcry that Congress representatives will change some of this, I think.
Yeah, well, that's the hope. How do these Medicaid cuts and coverage losses impact safety nets at the hospitals and community clinics that rely on the funding to stay open? Like that must be a big problem today.
Yeah, that's like my clinic. So I was medical director of Ward 86, like you said at the beginning. It is a federally qualified health insurance, FQHC. 96% of our patients are on Medicaid. Like that, we are totally dependent, and we provide what's called safety net care, meaning 30% of our patients at this HIV clinic are homeless. They're experiencing homelessness in the city of San Francisco, which is a pretty crazy city for housing costs. There is addiction. There's about a third. There's off and on addiction. And there's also food insecurity. This is a really low income population. So we have no other way to support our clinic but Medicaid. There's not like some philanthropist that's going to come out of nowhere, and support these clinics. So what will happen is with contraction, people will unfortunately have to lay off staff, and then there'll be less staff to do more work. And especially since some of the staff all they're doing is trying to keep people on Medicaid with these time-consuming paperwork every 6 months. So we'll be doing less with more, and it's going to be difficult, and people won't get as good of care.
Since you work in this area, what role should healthcare leaders and medical professionals play in pushing back against these policy changes and advocating for their patients?
A big role. I mean, there's just no question that if you're not an activist or someone who's thinking about policy and you're a physician, then get into that space, because this is what you do, right? This is what you do for a living, is you treat people and you try to help their healthcare. And that has to be done within a system. That has to be done within a system that pays for it. That has to be done. Policy in the federal government matters a lot. You're not just working in isolation. People having insurance matters a lot. So be activists, be advocates, not only with your Congress representatives, but writing pieces, being active with the American Medical Association, whatever it takes for you to be, for you to push back on kicking millions of Americans off their needed health insurance. It's just appalling.
And if you are listening right now and you are just one of my viewers, why should you care about this? If you're not on Medicaid, you've got enough money to survive, you're paying for your health insurance. Why should you care about this crisis?
Actually, because a sicker society will influence you, meaning your wait times will be longer if places like urgent cares and ERs are flooded. You won't get as good of care. Your people who support society being sick isn't helpful to your like convenience, sort of like going to a restaurant or getting Uber Eats, or like we just need a healthier society. We saw this during COVID-19. Actually, we had one reason we had worse outcomes in the United States is we're not the healthiest of people. Unfortunately, there is more rates of cardiovascular disease and chronic disease and being overweight, and we're just not the healthiest country. And then that slows down like your life, in that we're kind of interdependent on each other. So it does make your life harder if you're living in a country that has more and more illness.
And then for listeners who want to take action, what can they do?
Yeah, I mean, at this point, I know that we keep on saying, write your Congress people, but I mean, like, it matters. It actually really matters to call your representative. I would vote personally, be very active in the political process, because we're coming on midterms and there's some things that people are unhappy about, like gas prices and inflation. If you're unhappy, then vote. Definitely, that's how democracy functions. And then advocate as much as you can and publicly as you can, that it's just this simple. Like, of all the things that are controversial, you can say maybe what we decide in war or what we decide in other functions of society are controversial. I can't imagine that there's no poll in the world of among Americans that says healthcare coverage is controversial. People want healthcare. They want healthcare. They want their loved ones to live longer. They want biomedical research. They want NIH to be fully funded, and they want that. Any poll will say that they want life-saving discoveries. So there's nothing controversial about being loud about that other countries do provide healthcare for their populations, and those countries then, once you get that off the table, you can have better economic prosperity.
Let's switch topics for a second and talk about the vaccines. Yesterday, Trump changed the vaccines that we need.
Yeah, executive order.
An executive order. That's it. Sorry. Yes.
Yeah.
So, what's your take on that from yesterday?
So yesterday, what happened is that Trump signed an executive order that RFK Jr. had put in that essentially said that they're going to change the childhood vaccine schedule. And that's because executive orders is how this administration have managed to try to influence policy when this isn't exactly an executive order thing. Usually things like medical recommendations are made by experts who advise the CDC through something called the Advisory Committee on Immunization Practices, the ACIP. The ACIP is people who are outside of the CDC advising the country on what to do with immunizations. The ACIP was fired last July after RFK Jr. had started, and so there isn't great representation of high-level expertise in vaccines in the ACIP advising the CDC. So then, for bureaucrats again, and I say bureaucrats because Trump, of course, is a politician, but his HHS secretary is also not a scientist or a doctor. To put in executive orders that says we're going to change the vaccine recommendations in this country doesn't make sense. And the reason it doesn't make sense is the changes that they've made is to say the MMR vaccine, the measles, mumps, rubella, which is given as one vaccine. There's not even a manufacturer where you can get 3 separate vaccines. They want to separate those 3 vaccines. So the child will be stuck 3 separate times on 3 separate occasions. And beyond that, as a parent, you have to take time off work and get multiple shots. It's already hard enough to in this day and age to, take off time off work and get to the doctor. And then they also took 6 out of the 17 recommended vaccines and moved them from recommended to shared decision-making. And that was hepatitis B vaccine, which the reason we don't have chronic liver disease and hepatitis B is partially because we have such good vaccination rate, including the birth doses. And then they also took out hepatitis A and RSV monoclonal antibodies and rotavirus and meningococcal vaccine. So like meningitis, no one wants meningitis. So point being is that they did a lot of changes by executive order. And in the press conference or in the declaration of this, which was from the Oval Office, There's a lot of mention of the link between vaccines and autism, which is not true. There isn't a link between vaccines and autism. That's really been widely debunked. So to bring that up again, it's just not along the line of consensus, scientific consensus. So what this is going to make it harder is states are going to ignore it. So already all these states have come out and said, I ignore that. And then beyond ignoring that, the reason that recommendations around the CDC guidance is we have such a fractured healthcare system, like we talked about at the beginning, we don't have a national healthcare system, that if to get a vaccine covered for your child, it should be on the CDC recommendations. And then your health insurance will say, oh, it has to be given. I will pay for that. And without it being on the CDC recommendations, then the birth dose of hepatitis B may not be covered, for example, or hepatitis A vaccine or meningococcal vaccine. And then you're struggling to get your child if you're, those vaccines. So these things have impacts. Yeah.
Even making the measles, mumps, and rubella, making it 3 shots. I mean, if you can do it in one, just do it in one.
Yeah. No one wants a child stuck more than once. I mean, that's just like it seems really basic to me. It hurts.
Yeah, I know. As we wrap up, is there anything I should have asked you that I didn't ask you, and your final thoughts?
We are in a weird time, I think, in this country because we have to think about scientific consensus and how things should be managed. Like, I would have no idea how to build a bridge. And I would never, ever presume that I get to be the one who designs the bridge. I would want like a civil engineer who has gone through training to be the one who gets to design the bridge. And so there's nothing wrong with turning to people who have like had a lot of training and are in infectious diseases, for example, on vaccine recommendations, or went through school or see patients every day, to turning to them for the medical advice, because that's like, it's the same with the civil engineering. And so we shouldn't be in a place where the HHS secretary is making decisions without relying on scientific expertise, and kind of known scientific consensus and peer-reviewed articles and medical data. This is a strange time. And I go back to this principle that if you ask the question of American people, what do they want? Not say, were you mad during COVID? Did you hate wearing a mask? Like, that's the wrong question. Like, we're at this point. COVID's over.
Yeah.
COVID pandemic's over. We're at this point. Do you want life-saving biomedical research? Do you want healthcare for your family? The answers are always yes. They're really, really high percentages. And because we pay taxpayer dollars, and we pay taxes, and no one's really objecting to that, we pay taxes, those taxes should be used in a representative government for what American people want. So this needs to change. These kind of massive cuts and recommendations also made on non-scientific findings. This needs to change. We're in a weird time, but it needs to change.
Yeah, I don't understand why it became so political. Like, healthcare should be, your job is to save us, not not
of
become
all the
political.
things to be political. I totally agree with you. I don't get this one.
Yes.
I don't get this one. Yeah,
like, there's a lot of stuff that I can understand about being political, but this one is like, someone's having a heart attack, let's fix it. Let's make sure that they don't have a... Yes.
I want the cardiologist. I do not want the snake oil salesman. I don't.
Yes. I don't. Dr. Monica Gandhi, thank you so much for joining me. Thank you so much out there for listening. Let me know what you think. Put your thoughts in the comment section. And until next time, everyone, be safe.